Few words about thyroid cancer. Actually, first of all, I want you to know that thyroid cancer manner is relatively better than other types of cancers. Okay, so it's one of the least aggressive cancers in relation or in comparison with other cancers. Actually, we have four main types, and here we have also the lymphoma. Okay, lymphoma. Okay, we have five main types of thyroid cancer. I just like to remember them by putting them in a funny sentence, which is pure food, pure food in my abdomen. Okay, abdomen. So pure food in my abdomen. The P here is for the papillary cancer. The F here is for the follicular type. The M is for the medullary, and the A is for the anaplastic, and we have the final type, which is the lymphoma. Okay, let's start with the papillary thyroid cancer, the papillary thyroid cancer. Actually, it's the commonest type of thyroid cancers, and it's constitute about 80% of all thyroid cancers. It begins in the follicular cells of the thyroid gland. Actually, it's accurately diagnosed on the fine needle aspiration cytology. Okay, so FNA is capable of diagnosing papillary cancer, but you will find that FNA can't diagnose the follicular type of cancer. Okay, in FNA cytology you will find some confusion between the follicular carcinoma cancer and the follicular adenoma. Okay, let's get back to the papillary type, commonest subtype. It's accurately diagnosed by the fine needle aspiration cytology. Histologically, okay, you can find a character of the samoma bodies, which is area of calcification. Samoma bodies in the papillary type of cancer. Here we can see the samoma body, okay, area of calcification. Now, how does it metastasize? The papillary type of thyroid cancer actually usually metastasized by lymphatic. Okay, lymphatic. In the follicular type, you'll find out that it metastasized by blood, hematogenic. Okay, blood. Now let's talk a few words about the follicular thyroid cancer. This type of cancer are less common than papillary lesions. Okay, so the papillary is the first most common. The second most common is the follicular thyroid cancer. And actually, like papillary tumors, they may present as a discrete nodules. You can find a discrete nodules, okay, of follicular cancer, although they will appear encapsulated macroscopically. So if you look at it macroscopically, okay, you will find it encapsulated. But if you put it under the microscope, you will find some kind of invasion. Okay, you will find some kinds of invasion. Macroscopically, it is encapsulated. Under the microscope, there will be invasion. Unlike the papillary cancer, the lymphatic drainage is rare. Here, the hematological or the blood mets is more common, and this is why it has some higher mortality rate. Okay, and again, follicular lesions can't be diagnosed accurately by FNA. Okay, you have to take at least to do at least hemithyroidectomy, okay, to diagnose it. Okay, you have to remove the lesion and look at it and decide whether it is follicular adenoma or follicular carcinoma. Now let's move to the medullary thyroid cancer. Pure food in my abdomen, papillary, follicular, medullary, and anaplastic. When you talk about the medullary cancer, you are mainly talking about cancer in the parafollicular cells of the thyroid gland. Actually, the thyroid, okay, the parafollicular cells of the thyroid gland, the follicular cells of the thyroid gland, and the colloid. These are the three most important components of the thyroid gland: the follicular cells, okay, and the colloid of the thyroid gland, and the parafollicular or the C cells, which secretes the calcitonin of the thyroid gland, okay. And that's why the serum calcitonin may be elevated in the medullary carcinoma, because it's a cancer of the parafollicular cells which secretes the C cells, or the C cells which secretes the calcitonin, okay, I'm sorry, and the calcitonin may increase as a result in medullary carcinoma. The medullary cancer may be familial and occur as a part of the MEN2A disease spectrum. You know the MEN, the multiple endocrine neoplasia syndrome, okay? We have MEN 1 and MEN, okay, sorry, and MEN 2 syndromes, okay? The medullary cancer may be a part of MEN2A syndrome. The medullary carcinoma may spread by the lymphatic or the hematogenous pathway, okay. And but because this type of cancers, the parafollicular cells, is not related to the thyroid cells itself, okay, it's not derived from the thyroid cells itself, it mostly will not react to the radiotherapy. It will not respond well to the radiotherapy. Now let's move to the bad type of thyroid cancer, the worst one, which is the anaplastic thyroid cancer. The anaplastic is one of the least common types of thyroid cancer. It occurs more in elderly females, okay. Disease actually usually is advanced at the presentation, and often only palliative decompression and radiotherapy can be offered, okay. So here only palliative care and radiotherapy may work, okay. And it's a bad type of thyroid cancer. Finally, the lymphoma. The lymphoma actually respond well to the radiotherapy. Radical surgery is unnecessary once the disease has been diagnosed, okay. Such and in lymphoma again we can't depend on the FNA. We have to take a biopsy, okay. So what are the types of thyroid cancer that we can depend on? The FNA, the lymphoma, and yes, the follicular cancer. The last piece of information I want you to know is the presence of Hürthle cells, okay, in follicular carcinoma or follicular neoplasm. And actually the presence of Hürthle cells points toward worse prognosis of this cancer. So pure food in my abdomen, papillary, follicular, medullary, and anaplastic thyroid cancers, and the lymphoma, of course. Thank you very much for watching this. See you in another video.